suggested that something we could do for, or suggest to Zoom, is that they have a location tracker, so we could see where everybody was coming from and where they were actually located. I thought that would be interesting. But in the meantime, as you're joining the webinar, if you want to post into the chat box who you are and where you are, so we just get a little bit of a feel as to the audience that we have here tonight, that would be great. So we've got a few people here. Okay, so Kylie from Melbourne, Victoria from WA, Saraja from Adelaide, Mary from Wollongong, Sue from Albury region. Wow, they're coming in thick and fast all over the place. Morning Peninsula, Mossman, Queensland, where I'd rather be because it's probably a bit warmer than where it is in Melbourne at the moment. Great, okay. Fiona from Royal Melbourne Hospital. Lots of people here from all over the place, okay. Ipswich, Bendigo, Royal Adelaide Hospital, Melbourne, Frankston, Bundaberg, Barrel. Oh, someone from Barrel. Well, there you go. That's where our head office is now. Midcaster's head office is in Barrel. So someone from Healthscope, but that could be anywhere in Australia. I've done work at Healthscope in Darwin, at Canberra, Gippsland, yep, Berwick. Another one from Ballura, Lyme McEwen Hospital in South Australia, Wollongong, Orange as well, a few people there from Orange, so that's good. Now, it's got from, just make sure that you're replying to all panelists and attendees, so everybody else can see what you're actually posting. So just make sure that you click on the bottom that you're replying to all panelists and attendees so that people actually know, okay, what's happening there. Someone saying this series allowed your education to be heard by so many who may not otherwise have access. Thank you. So that's great. Sydney St George, Carberry, but usually Wollongong. Oh, that's a lovely spot over there in the west coast of Western Australia. All right, well, we've got quite a few people that have joined us, Anna, so I think we might make a commencement. So welcome everyone to the webinar from PACU to ward for high flow nasal oxygen therapy. And we're going to cover quite a few aspects that we might have covered in some of the other parts, but we're going to add another dimension to it. So I'd like to once again welcome Anna Adreos, who's the National Education Manager for Fisher & Paykel Healthcare Australia. And Anna has had a long history associated with that company, as she started with them in 2000 and since 2004 has been managing the education team in Australia. So she's responsible for the coordination and implementation of fully endorsed Australian College of Nursing clinical education seminars across Australia, and this extends to education support within Southeast Asia. Now, what I would like to do is to pass over to Anna. So just a couple of housekeeping things. Remember to use the chat box to communicate with us. We'll have a number of polls through this webinar and also some case studies. And we'll be asking questions. You can put questions into the chat box and we'll look at actually answering those. And at the end, then we will actually summarize some of those questions and provide some answers to you if time permits with that. Now, with the tech support, if you're having any problems with your tech support, we've got working in the background, we've got Greg and Abby from the Medcast e-learning team. So just post in the chat box to them if you have any issues with that, and they will then be able to respond and help you with that. And if that's the case, you could just put to, when you click on the down arrow, it'll have to Medcast admin as host. I think that might be correct. Is that correct, Greg?
Yep, sure is.
Okay, great. So that's how you can send a message directly to them so that it doesn't get lost in the plethora of other messages and things that we've got coming in. All right, so I'll hand over to Anna to share the slideshow, and I'll be in the background and moderating and looking at the chat box. Over to you, Anna.
Thank you, Ken, and thank you for the introduction. As Ken mentioned, I think this is the third in a series of 3 webinars we've been presenting with critical care and Medcast. And in this presentation, just going to bring it up on the screen, I want to focus on the use of nasal high flow and look at it in a little bit of a different way than what we have in the previous presentations, as I'd like to focus on the use of it in recovery. And these patients are quite different from what we're used to, certainly in acute care and in the ICU environment, and also in perhaps the respiratory medical ward. And we have a unique set of pulmonary challenges, I guess you could say, that we're going to look at, and we're going to kind of have a look at those in some detail, and then have a look at how nasal high flow can assist with this. And I'd also like to introduce the concept of nasal high flow in recovery and following the patient through into the ward. So essentially, you're keeping the patient on this therapy and they're maintaining respiratory care through into perhaps an acute ward or a medical or a surgical ward. And what we're seeing with the research that's come out is the patient sees real benefits in this, and there's some really good outcomes. They do very well. They don't tend to need acute care as much as perhaps they do if you cease the therapy, and it looks as though we are seeing some improvement in economic cost, which are early days. So that's kind of where we're going with this particular presentation. And as Ken mentioned, we're going to mix it up a bit with some case studies, so get you guys to think a little bit, and that also helps with the application. So looking at the overview here, well, looking at the challenges you're presented in post-op care, and this is nothing new. You guys are very familiar with patients that present a challenge. They present complications, and I want to overview those complications, and that's kind of a systemic thing. And look at what contributes to these complications. This is really the influences we see with these patients and how that contributes to the challenges presented. And certainly we treat patients with oxygen. I want to have a look at how we do that. And it becomes quite clear that we use many different interfaces as you need escalating support. And I want to kind of focus on that a bit so you can see the difference between what we currently do and what we can achieve with nasal high flow that provides real benefits for these patients. And you can look at the therapy in a different way as you're able to do so much more with the therapy. And then we'll finish off by having a good look at what the Airvo device can achieve in recovery. And if we get a chance, we'll have a look at how it's set up and how it works and what all the buttons and devices mean. It's a very, very simple device, so that won't take so long. So in terms of the challenges to post-op care, this is something that we're quite familiar with. It's something that we've been presented with since, I think, the beginnings of surgery, and the aging population has been a challenge. We are probably living twice as long as what we did 50, 100 years ago, and we are now operating on the aged routinely. And this is pretty much due to the fact that surgical interventions and techniques have improved and developed, and we're able to do this. We have a huge problem with obesity. Despite the fact that we address obesity, it's a very high profile comorbidity, and we have done so much with regard to research to focus on obesity, it remains to be a real challenge. And you guys in surgery will know that post-surgery, your obese patients are going to be your challenging patient in recovery. And of course, we are also treating chronic health problems far more successfully. So we will see those patients in surgery, and we have far more complex surgeries. So now you kind of get the picture. We have an aging population, a lot of obese patients, very complex surgical procedures, and you put it all together and that kind of increases your challenge. So it's due to, I guess, the advancement in surgery that we've come upon these problems, and we're dealing with them, but we still see challenges presented to us. And when you look at the complications associated with these challenges, it's not restricted to one particular system. We have a myriad of complications, whether it be respiratory in terms of the pneumonias and that electrolysis, or circulatory, perhaps some massive blood loss. urinary, perhaps it's some kind of urinary retention, gastric with regard to vomiting or nausea, and the obvious ones of infection where you have the obvious signs of infection. So it's a systemic effect. And when you look at the numbers, millions of surgical procedures are undertaken annually. And despite that, and everything we've done to address the complications, it is quite consistently sitting at about 35%. So a standard postoperative complication will occur 35% of the time. Now, it brings me to the first poll that Ken's going to bring up. We just want to ask the question to see what your thoughts are on the one system that you think perhaps presents the most common complication.
So of all postoperative complications, which system presents with the most common complications? So we're getting a lot of people jumping on different things here. And I think this is very relevant for the PACU environment. Judge Dome some years ago said that the most important room in a hospital was the recovery room, because that's where patients were at their most vulnerable, and that respiratory complications were one of the most preventable problems that could be encountered in that room. And by the look of most people who are actually voting, that's what they're thinking as well. So let's end polling in 5 seconds, and then we'll check the results. Okay, so here we are, Anna. Can you see the results there?
Yep, excellent. That's it. Very reassuring.
So the majority of you have said quite correctly, 74% respiratory is it. So over to you, Anna.
Thanks, Ken. Just bring back the presentation. Okay, respiratory, absolutely. And when you look at where respiratory sits, pretty much overall 10% of all surgical complications will be respiratory. And when you isolate that to abdominal surgery, it quadruples up to 40%. And when you look at the research on this, it tends to be simply because the abdominal surgery is so very closely situated to your respiratory system and your diaphragm, and this is where all the compromises occur. So this is no secret. This is something that we've known for some years, and it's quite persistent. So despite many advances, it remains to be the most common complication, and it's literally the respiratory system. And just to perhaps focus on post-op pulmonary complications a little bit more so we can define it somewhat, it becomes quite clear that it is really any respiratory compromise presented is considered a pulmonary complication. And look, you can go by the guidelines from one of the more recent European reviews, and then you can extend it out to many of the other terminologies for respiratory complications. And I guess if we wanted to perhaps sort of define it somewhat more, we could look a little bit more precisely at those respiratory complications that occur immediately post-op. So I'm talking sort of like the atelectasis and the bronchospasms, the hypercapnias, the hypoxias, the pneumothorax, etc. Those are the ones that are most treatable. They are going to occur in recovery. And that's kind of what we are going to be looking at when we talk about the different ways that we are treating this particular challenge. And what influences these complications? And when we look at the risk factors associated with post-pulmonary complications, you can kind of fit them into 4 different groups, so to speak. You've got your patient factors, and we've touched on this. Age is a huge factor with regard to complications, and we know this. The elderly population often have a lot of comorbidities, and they're going to be at a higher risk of some kind of respiratory compromise. Obesity causes huge dysfunction in your volumes. You have far lesser functional residual capacities, so you are less equipped to deal with an anesthetic. If you're a smoker, that is hugely toxic to your respiratory system. One of note is OSA, or obstructive sleep apnea. That is probably one of the most undiagnosed comorbidities you're going to see in surgery. And when you look at the extent of the population that's undiagnosed, it's probably 80%. And when you look at the statistics for OSA, about 25% of the population has OSA, and most of them are undiagnosed. And I know Ken's going to take you through one of the questionnaires you can go through, the stop-bang procedure, which allows you to identify if the patient is at risk, which is invaluable. As we know with OSA, it causes a massive challenge to the airway post-surgery after an anaesthetic. So you've also got your anaesthetic factors, which is the drugs themselves. And we know anaesthetics create like a systemic hypoxia. And there's a good reason for that. You're wanting someone to be sedated and paralyzed. So you've got a suppressed respiratory system. You have no muscle control. Your respiratory system isn't working as it should. There's no respiratory pattern. And you're controlling ventilation for that patient. So yes, of course, it's going to be a major factor in post-pulmonary complication. And as we know, many patients are going to have atelectasis post-surgery. In fact, 90% of the patients out of surgery will have some kind of collapsed lung, and that's very well accepted. Surgical factors in terms of where the surgery is a huge determinant. And as I mentioned, the closer the surgery is to the diaphragm, the more likely you are going to see a reduction in your functional residual capacity, and you are going to have a compromise as a result of lesser volumes. And of course, post-surgery opioids, they are a massive respiratory suppressant. And I think when you've perhaps got a patient that's persistently breathing at a very low respiratory rate, you could perhaps consider that they are having a lot of sedation, and your aim here is to improve their ventilation. So we have risk factors associated with post-pulmonary complications. They present a challenge, and we're very familiar with them, and we treat them, but nonetheless, they seem to be reasonably persistent, should I say. And the consequences are probably, if we broke them into two groups, one of safety, where you are increasing your risk of intubation. You have a real risk of readmission into the ICU. And of course, you're going to be working harder. You're going to be attending to that patient for longer. Economics, that's always a goodie. We've got to look at the cost efficient or the cost factors involved in challenges. And yes, that will prolong the stay in recovery and perhaps the hospital length of stay. And perhaps there's a very good chance of readmission. So that are the consequences that we face with these complications. And if I was to perhaps look at two complications of the respiratory system that have been most studies, are the most common, and are most treatable, I would say that it would be hypoxemia and atelectasis. And you will all be very familiar with these two challenges. Hypoxemia is reasonably common. Up to 55% of your patients will become hypoxic, and I'm talking with that's less than 90%. And that's going to depend, of course, on your factors, your risk factors, your age group, your comorbidities, your respiratory compromises, and your surgery. All of this comes into play. And when you look at atelectasis, that's a whole new ballgame. Most of your patients are going to be atelectic after surgery, and it is simply because you don't have the volumes. The anaesthetic has decreased your residual capacity. The way the positioning of the patient has been in theatre is going to decrease the volumes, and it's literally due to the fact that the diaphragm has passively shifted upward and your volumes are smaller. And as I said, the closer the surgical site is to the diaphragm, the smaller your functional residual capacity is going to be, and the higher the likelihood of atelectasis. And the thought has been, with some of the work that I've recently read, is that perhaps when you have atelectasis, you have a higher chance of pneumonia. Now, look, that's something that is going to be researched, but the thought is that there is a link there. There is a relationship between collapsed lung and pneumonia. So how do we treat this? And this is something we've been doing for, if we looked at this next study, I think it's about 173 years. We provide oxygen. We provide oxygen therapy. Oxygen is efficient. We know what it does. It's a very efficient way to treat hypoxia. It works very quickly. We often don't need so much, and we get a very good response, and it continues to be effective in the management of patients. And what we tend to do with these patients post-op is we start slow, we start low, we're quite conservative. So let's say we start off with some nasal cannula, and we'll probably give a couple of litres, 2 or 3 litres of oxygen. Should you not see what you're looking for, should your saturations not improve to what you'd like, you're probably going to up the flow to, let's say, 6 to 8, 8 to 10 litres of oxygen, and you're going to be running a Hudson mask, something like that. Should you not quite be happy with where the patient is sitting, you've got more options here. You can perhaps run a Venturi system, and with a Venturi system, you've got the ability to give a certain percentage of oxygen, and you're driving some flow through there. You've got 30 or 40 litres of flow with oxygen coming through. And once you reach that point and you're still not happy with where the saturations are, you've got your non-rebreather, where you have an opportunity to give a reasonable amount of oxygen, 60 or 70% on occasion. It's going to depend on the response of the patient. And all of these applications is using 100% oxygen to varying degrees. Now, often we're going to see responses that are favourable. On occasion, we're not. So what we want to do with the next couple of slides is introduce you to a case study. And I think Ken's going to take us through the case study, and then we're going to ask for a poll on this. So have a good look at this case study. And the next poll we're going to ask you is we want you to identify how many risk factors you see in this case study that are presented by George. How many post-pulmonary complication risk factors do you see presented with this particular patient?
Thanks, Anna. So as we go through this, you might want to just keep a little tally. So George is a male of 68 years of age. He's got a BMI of 39 kilos per metre squared. So that puts him in the severely obese category. He's a smoker, and he's been diagnosed with obstructive sleep apnea with a stop bang score of 6. Now, if you haven't heard of this before, this is a questionnaire where people are asked 8 questions. And if you had 0 out of 8 questions you answered yes to, then you would have virtually no chance of having sleep apnea. So 6 out of 8 means that he has severe potential for obstructive sleep apnea. Now, he's got poor compliance with home CPAP because he finds it uncomfortable and keeps pulling it off overnight. So he's come in for an emergency laparotomy for a small bowel obstruction, and the surgery proceeds for 2.5 hours. Anesthesia is induced with remifentanil and propofol, neuromuscular blockade with rocuronium, and fentanyl was administered intraoperatively for some post-operative pain relief as well. And overall, the surgery was uneventful. Now, he arrives in the PACU on 2 litres of oxygen via nasal prongs. And because the anaesthetist is a little bit concerned about him with his respiratory history, a blood gas has been done. And it shows a PaO2 of 76, PaCO2 of 52, pH of 7.3, and his SaO2 is 89% at this point. Now, he has transient apnea, triggering large decreases in oxygen saturation. And the recovery room where he has been admitted to doesn't have any CPAP machine. So he's put on 6 litres per minute of oxygen via a Hudson mask. And after 20 minutes, his SATs have come up to 90%, but his respiratory rate is 8 per minute. So the poll question that I'm going to ask you, and you can actually move this out of the way, excuse me, is how many risk factors for postoperative pulmonary complications are present in the case study? Okay, getting a strong response here. A lot of people identifying quite a few things. So I'm going to end the poll in about 5 seconds. Okay, so ending the poll now, and I'll share the results. And here you can see that the majority of you said 8+, some said 6, but it's definitely right up there with all of the different risk factors. So I'll stop sharing that, and then Nana, if we can move on to the next slide and go through.
Okay. I'll just, right. Okay, we'll go through them. So I'll highlight them, and Ken, you want to discuss?
Yeah, sure. Okay, so as we said earlier on, older age males, particularly this one is 68 years, so it's definitely a risk factor. Next one should be the BMI of 39. Yep, very high. Smoker, yes. And then I think the next one will be obstructive sleep apnea. Yep, so that's 4 so far. And then emergency laparotomy and 2.5 hours of surgery. Now, I just want to come back to something that Anna said before. When patients have surgery and we put them in a supine position, it can reduce their functional residual capacity by about 25%. So that's going to reduce the ventilation of the lungs. So the next couple we've got is Remember, fentanyl and propofol, both of those have a respiratory depressant effect, as does fentanyl. And his SATs were 90%, and his respiratory rate was 8. So a little bit low considering he was on 6 litres per minute. So let's look at the next question, and that is, there's a poll I think we're going to look at, so I'll launch that.
Perfect.
So the poll says, in this case here, do you believe that application of 6 litres per minute of oxygen will help increase George's respiratory rate and in turn improve saturation and ventilation? So the choices are yes, no, or not sure. We could put in phone a friend or 50-50 or Summer Lifeline, something like that. We haven't got those options though. So here we are, we're going along, and a vast majority of you are highlighting one over the other. So I'm going to close the poll in 5 seconds. So here we go, we'll stop the poll and I'll share the results. So Anna, what do you think about that? The majority of people said no.
That's interesting. Look, it's one of those questions that a little bit tricky, as I guess you sort of want to perhaps reflect on what does oxygen treat? And oxygen is very efficient in treating hypoxia. So that alone, you would think, would improve saturation. So when you have a look at George's numbers, I think from memory, we're sitting at 90%. Not fabulous, but we're maintaining ourselves. So that alone is doing somewhat of a job, but it kind of reflects the limitation we have when we're only able to give oxygen, and we don't have infinite amounts of oxygen to give, and we can't give infinite amounts of oxygen. It's just so non-compliant. Now, when you look at the ventilation side of things, what do we need to assist with ventilation? And is it oxygen? I would not say that would be the number one. Ventilation is all about gas exchange, and to enable gas exchange, you need to allow gas to go into and out of the lung with minimal work. So it really is more about assisting and ventilating through the assistance of gas exchange, so allowing air entry and air exit. So it's all about work of breathing and respiratory rate. Oxygen is not designed to achieve that. So when you're in a position where you're dealing with a reasonable amount of oxygen and you note the respiratory rate isn't going where you'd like to, the saturation isn't quite meeting the mark, and you've maxed out on your 15 litres with your non-rebreather, where do you go from there? And the next step, and it's very well researched and it's quite well accepted, is CPAP, or non-invasive ventilation. And what is interesting though, is that it's not that often utilised in recovery. And there's many reasons for this. I think one of the main ones is that compliance is very, very low. It is very overwhelming for the patient. It's very uncomfortable for the patient. And just the whole factor of the face, that you've got a mask that needs to be tightly sealed onto the patient. You've got a big flow running through. You need to keep the mask on. They need that pressure. The pressure is what is allowing them to ventilate. That in itself is a compliance issue. It's a very big challenge. So you tend to lose the battle, and it's not as effective or successful as it should be because it's just simply not staying on the patient, and it's down to compliance and tolerance. So we've looked at this, and a lot of studies very recently have looked very closely at this, and this is when you can start to perhaps look at the options you have available to you, and we haven't had anything available to us until recently. Now we look at the option of nasal high flow. It has opened up a whole new realm of application. So now we can achieve not dissimilar to what we can do with CPAP and BiPAP from what we've seen by the research, but we are doing it in a very different way. We have a system that allows us to give reasonably high flows, and I'm not talking about just oxygen here, I'm talking about air, and we can certainly titrate the oxygen should you need to. So it's another way of looking at respiratory support. We're not dealing with the oxygen, we're not going to oxygen, we're going to flow. So this is an air system, an airflow system. And if you get very, very good responses with this particular application at your 50 litres of flow, and let's say George was placed on 50 litres of air and his saturation sat at 95 and his respiratory rate came up to 15, You thought, great, good result. If you saw such a good response with air, with George in recovery, don't you think that's a good argument for the use of such a therapy in the ward? It is air. We haven't utilised any oxygen. It is a completely different way of looking at how to maintain these patients. So this is the concept that the research is now looking at, and we'll go through some papers that have highlighted this. So now we can achieve up to 50 litres of mixed flow, whether it be air or a mix of oxygen. We can certainly run high flows of oxygen should you wish to, but often you don't require it. And the way we get around the whole system is because we heat and humidify the gas. And I'm going to review the mechanisms. We have covered the mechanisms in the previous sessions, but I think it's worth reviewing them and reminding ourselves of the mechanisms behind the uniqueness of this therapy. So we have sort of 3 or 4 unique mechanisms at play here. Humidification is kind of the mainstay. It enables the flow. You could not deliver the flows you do without the humidification aspect. And of course, physiologically, it looks after the integrity of the airway. And that is literally delivering body temperature saturated gas to the airway. We had this unique mechanism of dead space reduction, and I'm going to show you a little simulation of what happens in your airway as a result of driving high flow through the airway. There is some pressure. It's very, very conservative. It's nothing like CPAP, but there's no question it is providing some form of support. And flow is really referring to the sort of turning oxygen therapy on its head, so to speak. So we're now talking about flow, and we're using oxygen sparingly. Oxygen is the drug, so it makes absolute sense to titrate that in should we require it. So now we have the option to use flow, and if you think you might need some oxygen, you have that in your back pocket, and you can titrate that in, which we'll have a look at. Humidification, simply placed, it is the delivery of water vapor through a tube, through the nasal cannula, and water vapor is physiological. We heat the gas up to 37 degrees. That makes it body temperature saturated. That's kind of what our lung requires. And we thought we'd throw the COVID in there because that's kind of the elephant in the room, just to show you where COVID sits into the equation when you look at the size effect. Water vapor is infinitely small. It will not transfer anything else. It won't transfer pathogens from A to B. Whereas when you look at the other side of the delivery system, like aerosol delivery, nebulization, they are very, very capable of transferring pathogens from A to B. So that's something to keep in your back of the mind. And keeping the gas warm keeps the humidity as vapor. So that's what's going on in the chamber. It's 37 degrees, it's saturated. That's what we are delivering into the upper airway of these patients. Temperature is important, and just showing you the relationship here, we control temperature quite precisely, because if you do that, you control humidity by default. And of course, the recommendation of delivery is 37 degrees, as that's physiological, and we know how much humidity is held in that gas when it is completely saturated. So that's the concept of humidity. That's what we're delivering. And why we do this is to condition the gas. We need to look after the airway. And this is all about functions of the airway. One of the main ones is defense. And we have mechanical defenses, and we have the lower airway defense. Mechanical defenses are, I'm referring to the cough reflex, the sneeze reflex. They are often intact. They are often not so strong, certainly in the recovery patient. So you cannot rely so much on those processes. It puts a lot more emphasis on the lower airway defense. And this is the mucociliary transport system. This is our main defense system. It involves the movement of mucus up the airway. Cilia drive this mucus up the airway. All the debris that comes into your airway on a daily basis is picked up by that mucus and it is cleared. It is very, very effective. It works consistently. It is always moving up, whether you breathe in or you breathe out. And it's pretty much your entire conducting part of your airway is made up of this particular structure you see in front of you. You've got your mucus layer, your cilia layer, and your cells. And the delivery of conditioned gas ensures we preserve good function of the defense system. That's humidification. We kind of understand that. Now, the next really unique mechanism is that of dead space. And I want to very briefly remind you where the dead space and what the dead space is, and then I'll show you what happens when we run high flow through the dead space. So this is a nice complicated anatomical diagram, and you can see on the right hand side we've got the conducting part of the airway, we've got the gas exchange part of the airway, which is the alveoli, and I'm going to show you where your dead space sits. That's pretty much your dead space. So if you wanted to define it, it is that part of your airway that does not take part in gas exchange, and in a nice healthy person it pretty much sits within the conducting part of the airway. So all those bits that don't take part in gas exchange outside the alveoli, that's your dead space. In a healthy person, it's restricted to that area. When you become unwell, on occasion, your dead space will increase, and that is because dysfunctional alveoli become dead space because they no longer take part in gas exchange. They add to your anatomical dead space. They are your physiological dead space. So you increase your dead space. And the concept of that is the fact that you start to challenge alveolar ventilation. And it really is sort of about numbers and looking at the relationship between your tidal volume and your dead space. So to show you that a little bit more clearly, I'm going to bring up an app that will help clear that. I'll just bring this through, close that off. Sorry, just give me a second. Now, if I was to say to you, can we see that slide?
Yes, that's good.
Great. Okay, if I was to say to you, what you see in front of you is a simulation of an airway on the right-hand side, and we've got a graph on the left-hand side with some volumes, and this patient's breathing at a rate of 12 breaths per minute, and I've got some numbers here that kind of breaks up the key. The square box is your tidal volume. The white part of the box is your alveolar ventilation. That's the important, useful piece of your tidal volume, and the black bit is your dead space. So that what makes up a respiratory cycle. So you can instantly see not all of your tidal volume makes its way into the lung. You need to use some of your tidal volume to fill up the dead space. That's just a physiological concept. Now, in a nice healthy airway, it's about 30% of your tidal volume. And if I was to give you some numbers here, this is kind of what we're looking at here. We look at the normal pattern of breathing. If the tidal volume was 500 mils, dead space is about 150, and this is breathing at 12 breaths to a minute. Now, instantly you can start to see what happens when people change their breathing. When you become shallow breather, your tidal volume decreases somewhat. Your dead space does not. It remains consistent. So the result of this is the fact that you compromise your alveolar ventilation. And you can see the opposite is true with deep breathing. It's rather efficient on occasion. Your dead space remains the same, but you can see as a result, you're actually utilizing more of your tidal volume. Now, if I was to provide a little bit of disease to this lung, let's provide sort of reasonably severe lung disease. The first thing you see here is the respiratory rate has gone up. And as a result of that, the patient is trying to maintain their tidal volume. And you can also see that the ratio of dead space to tidal volume has increased. This is the black part of the square. So now we have a situation where the patient is actually using more of their tidal volume for dead space than alveolar ventilation. And this is where they start to struggle. This is why no oxygen is not enough. You perhaps will provide some oxygen for these patients to perhaps help them recover, but it's a losing battle because they simply don't have enough volume. Now, when you add high flow to a patient that is in this particular compromise, you can see very clearly here how the dead space has been reduced. You have flushed out some of that dead space, and in turn, you have improved their alveolar ventilation. You have decreased the respiratory rate as a result, so you've maintained them. Now, we're not saying on every patient this is going to be the cure. This is treating a symptom, and it perhaps will give you some time. Maybe it is enough to manage this patient as they go through their exacerbation. So this is where dead space fits into the equation, certainly with regard to high flow. Now, going back to the presentation, the third mechanism I want to make sure you understand is that of pressure. And look, I don't want to spend too much time on this. I think suffice to say that high flow is not CPAP. Certainly some of people call it a dynamic positive airway pressure. It is a changeable airway pressure. But I think when you look at CPAP versus high flow, CPAP is a constant pressure, and that is driven in by a variable flow. With high flow, it is a constant flow, and it is driven in by a variable pressure. The pressure constantly changes, and we now know, and there's a lot of research to support this, that the pressure is only on expiration. It is not extensive. It certainly is nothing like CPAP, but we are seeing very, very similar responses when we deliver therapy. And if you wanted to put a number to a flow, and look, this is, I'd say this with caution, a couple of studies have found this, that very, very loosely, every 10 litres of increase in flow, you get about a centimetre increase in pressure. So there is something in it, and certainly it contributes to the resolution of atelectasis and recovery. And there is no question that the high flow achieves this. We've seen some really good studies on this. Now, just to show you visually how this looks, there's some great videos that were done in Queensland some years ago. This study managed to utilise the EIT therapy, which is essentially using a set of electrodes that's placed around the base of these patients' alveoli, and you can see in real time patients breathing in and breathing out. And what this study did was they looked at post-cardiac surgical patients. So these patients all have a degree of atelectasis, and the aim here is to extubate early and re-recruit their lung. Often their lung is just collapsed. It's not unhealthy. It's the heart that's perhaps not doing so well. So they just need to re-recruit, get them ventilating well. And they decided to do a trial on the difference between extubation onto 2 litres of oxygen and extubation onto 50 litres of air. And they were able to utilize this technology that gives you a graphic similar to what you see here. So you'll see this video running in front of you, and this is what we would see if I put EIT on a nice, healthy person. You've got really good recruitment of both sides of this lung. You can see there's a bit of functional residual capacity there on both sides. So this is what they would love to see post-surgery. But of course, with your cardiothoracic patients, there is no way you're going to see a nice, healthy lung like that, certainly upon extubation. Then the next slide shows us an actual patient. This patient was initially placed on 2 litres of oxygen and then transferred onto 50 litres of air. And you can see initially there's absolutely no recruitment whatsoever. Very, very poor recruitment on one side. And 2 litres is not designed to recruit your lung. They then place 50 litres on this patient, and you instantly see the recruitment. And that is where the flow advantage is. And you can see from a completely atelectic lung to a lung that is not completely open, but you've opened 90% of the alveoli. So that is the advantage of being able to drive a decent flow into the upper airway in these lungs that are atelectic. And in recovery, they're often not unwell, they are just collapsed. And it's an anesthetic byproduct of the fact that the lung has collapsed post-surgery. Now, the third concept here is that of flow. And because we can give a decent flow, we can start to look at what's in that flow. So are we giving just air? Are we giving oxygen? We can be a little bit more precise with what we're achieving here. And look, the next slide is a little bit busy, but I'll walk you through it. If you have a look at the left-hand side slide here, you can see this little mound here is inspiration. And it's not a volume. This is a flow rate. So what I'm referring to here is, let's just say this was picking up my flow rate, and I started off with a rate of 0, so I'm not doing anything. I start to inspire, and very, very slowly, I start to inspire, and my flow rate speeds up, and I start to inspire at a faster rate of flow, and I reach a peak. My peak inspiration is 35 litres, and then I slow down again. So I've reached my peak, and I'm still inspiring, but I'm slowing down again. So that is inspiration. Now, in this graph, you've put me on 10 litres of 100% oxygen. So that's this blue bit here. So you can instantly see when you give somebody 10 litres of oxygen, you're not going anywhere near their peak inspiratory requirement. You're providing just 10 of the 35 litres. So I'm going to inhale about 25 odd litres of air. So the resulting oxygen concentration is very, very dependent on how much I entrain. So we don't know, because I might take a bigger breath the next breath, or I might take a smaller breath the next breath. It's variable. This is not exact science. Now, when you translate that to the nasal high flow, I'm now going to give myself all of that flow. I've given myself 35 litres. And because I know that's pretty close to what I'm sitting at with regard to my peak inspiratory flow, I'm going to set the FiO2, and I know I'm going to be pretty close to it. And I might set it 30, 40%. So the benefit of being able to give these flows is the fact that you can be more precise with your oxygen, and often you can be very conservative with your oxygen, because we're now using air as a tool for respiratory support, and we haven't been able to achieve that before. So those are the concepts, I think, that are really important to understand. This is what the Airvo can achieve, and we'll have a look at how we can achieve that after we have a look at this next poll. So I think the next poll is another case study from memory. So we'll bring up the slide and have a read of Mabel.
Okay, so it's Mabel has arrived in the recovery after emergency surgery for femoral artery repair. She's in respiratory distress with a diagnosed right-sided pneumonia. She has a respiratory rate of 35, heart rate of 102, SATs of 94, and the Airvo is set to the following parameters. So temp is 37 degrees, flow 35 litres, and the FiO2 is 32%. And the poll, if we can just bring up the next part there, Anna.
Oh, sorry, yes.
So people can see that who can't see that. Okay, so her vital signs indicate which settings should be altered. So temperature down, flow up, FiO2 down, or FiO2 up. Quite a lot of activity here, people thinking about it. Okay, so I'm going to close the poll in about 5 seconds. Number of people putting through in the chat box that they think question 3 or flow up. So that's good that you can answer there rather than participating in the poll. Okay, so I'm going to end that now and share the results. And Anna, what do you think about that?
Happy with that. Very good. And I guess so, why? And that's going to be a rhetorical question because you're not going to be able to answer it. But I think looking at Mabel, her saturations are comfortable, acceptable. It's her respiratory rate that is a concern. It's almost double what it should be. And look, her heart rate's up there as well, but they're not exceptionally high. So yes, now that we have the ability to address worker breathing, to address respiratory rate, we can. And there is absolutely no requirement to change the FiO2. She's very happy on 32%. So yes, the flow would go up, and look, our suggestion would be, and this seems to be the recommendation for a lot of recovery applications, is around 50 litres and titrating your oxygen sats to 30%. So well done. It gives us a good understanding of the nasal high flow therapy. So that kind of brings us to the Airvo. And as you possibly are aware, many of you are aware, you've got the ability to control your humidity, which is pretty much your temperature. You have the ability to control your flow, and you also have your ability to control your oxygen. And of course, the oxygen is delivered externally. As we know, you titrate that according to your SATs, as we've just seen. And the Airvo device is kind of like an air entrainer. So you set the flow, and the percentage is set separately. And as you change the flow, the percentage will change. So you need to account for that, which is what we did with Mabel. And if I was going to perhaps summarize how nasal high flow treats symptoms and what it treats, it would be perhaps simple to put it into a table something like this, where you look at your humidification side of things, and we know that manages defense. It maintains or preserves the mucociliary transport system. So there is how you can manage your hypersecretion and congestion. The flow, now that we can actually identify flow as a separate therapy to oxygen, we know flow is a huge assistance to worker breathing and respiratory rate. And when you look at that patient in recovery that is perhaps hypoventilating, we've found that the assistance of around 50 litres of flow provides a physiological benefit for these patients to improve their respiratory rate, which they are going to do as they come out of the anaesthetic. And oxygen, of course, you know, it's interesting. Oxygen is a drug, and it's really useful, and we've used it for 100 years, but it's very limited in its use, and it really does just treat hypoxia. So now we kind of have this myriad of tools available to us that we can really effectively treat these patients far more precisely than what we have been able to achieve before. And it kind of opens the door for certainly a lot of research and evidence that's going to certainly come about in the next couple of years, and looking at patient groups. And if I could just perhaps run through a couple of studies that have provided us with some answers. I don't want to take you through all the evidence, because there's quite a lot of evidence coming out of PACU, but perhaps framing the research where we all started. It started in ICU. We've done some really good work in emergency. Certainly, there's very good support for the use of nasal high flow in treating acute respiratory failure. There's no question. In ICU, it reduces intubation, it prevents intubation, you can get early extubation, and it does reduce mortality. And in emergency care, it significantly reduces dyspnea, respiratory rate, and improves oxygenation. And just more recently, we've seen some really interesting stuff coming out of the ward, which I'll show you. And at the other end of the care, at palliation, it certainly maintains comfort. It doesn't actively improve care. You're not escalating in care, but you're managing those patients far better and outside of ICU. So in terms of critical care, there's a lot of support for the use of nasal high flow to reduce respiratory rate, reduce work of breathing, improve end expiratory lung volume, which is essentially tidal volume, improve oxygenation and comfort. And in the ward, evidence is emerging. And this slide takes you through sort of 5 or 6 studies. I don't want to take you through all of them, just perhaps a couple. I would mention, though, that top study there is a fantastic review on the use of nasal high flow in perioperative medicine. It takes you through the use of nasal high flow through from surgery, theatre, into post-anaesthetic care, and it's very objective. So I would encourage you to read that, if nothing else. And this study here was done on the very, very bariatric patients. So it's one of those very, very challenging patient groups. They did quite a unique intraoperative strategy of open lung approach. So they managed to recruit the lung surgically and maintain it as such. And then they had 2 arms of the study. The nasal high flow therapy was actually put on the patients pre-extubation for 1 minute. And the thought here was that if you can put them on high flow prior to extubation, you can avoid the de-escalation of de-recruitment of alveoli that you see once you do extubate. And the other arm of the study was standard oxygen therapy. Of course, that was post-extubation. And they found when they looked at the 2 arms of the study and they looked at hypoxemia and atelectasis, there was a huge difference here. There was a 50% reduction in hypoxemia with nasal high flow compared to Venturi, and there was a 40% reduction in atelectasis when they compared nasal high flow to Venturi with the bariatric patients. So promising stuff, and I think we'll possibly see some more work coming out of that patient group, because they're a big challenge. And a study done a couple of years ago in Auckland, which was really, really useful as it was done in the ward, highlighted the usefulness of a couple of things. A, that nasal high flow can be used safely outside of an acute environment. And B, the success of this therapy is in the use of a specialist team. And this team in Auckland was the patient at risk team. These guys were activated, so to speak, in response to a patient that perhaps needed high flow, and they successfully managed most of their patients outside of the ICU with early intervention and close attention to these patients. And I think that was the key behind the study. It was an observational study, and yes, more work needs to be done. But in terms of maintaining ICU beds and keeping patients out of acute care, it's really promising. And looking at the numbers, they were mostly concerned with respiratory rate, heart rate, and SpO2, and they were very significant differences. This is before the introduction of nasal high flow versus after. And of course, the acute care team was responsible for application. And another interesting study that was done in the UK along a similar vein, and this is just an abstract at this stage, this is ongoing. They initiated the study with the intention to try and ease the pressures in their ICU beds. And this particular hospital just had 100% capacity in their ICUs consistently. Once again, a prospective observational study, as more work needs to be done, but of the 18 patients that they identified for the abstract, 14 out of the 18 were on the acute medical ward. 11 of the 18 were commenced on high flow outside of the ICU, and otherwise they would have gone to ICU prior to the activation of the acute interventional team, and just 2 of those were admitted. So they saved 9 admittance into ICU, and this is just the abstract, so the study is ongoing. So really exciting research coming out of the ward environment, which I think is valuable. And I think this is where we're seeing not just a cost saving, but really good patient outcome outside of acute care. And just to summarize with regard to this particular patient group, this was just a set of 3 case studies. They all had OSA, quite severe OSA, and they were all very severely obese and reasonable challenges post-surgery. And the point I wanted to note here is they did extremely well on nasal high flow, and 2 of the 3 patients in this case study group were managed well on just air. So this shows you the physiological benefit of being able to give high flows of air, certainly in the post-surgical OSA patient, which is not uncommon, certainly when you identify these patients before surgery. And in terms of, I know we're going to run out of time, so I just very quickly want to overview the therapy and see if we get a chance to run the vid. So the setup involves multi-patient use for recovery, and we're able to achieve that as we run a set of nasal cannula with a filter. So that is what's placed on the circuit, and the circuit in the chamber is maintained and placed on the airvo for the 24-hour period, and the filter in the cannula is what stays with the patient. So that allows us to achieve that therapy. And setup wise, this is very, very quick, takes you through the setup in super quick time. And it's pretty much, I think, from memory, a 4-step process. So you're going to attach the adapter to the chamber, you're going to attach the feeding tube to the adapter, you're going to attach the chamber to the airvo, and then you're going to attach the breathing tube to the end of the airvo and spike the bag. And your setup is ready to go. So at the beginning of each shift or list, this is what you do with your airvo, and it's maintained throughout the 24-hour period. Okay. So there we go. So that gives you a snapshot of the use in recovery and use on the ward.
So there's been a couple of other questions coming. If you maybe go to the final slide there, which has got the post-webinar QR code on it. So now there have been a couple of questions that have come in. One person's asked, please explain the difference between using Optiflow, Airvo in PACU. In terms of that, would you like to talk about that, Anna?
Optiflow, Airvo in recovery?
Yes.
So the difference, you mean?
Yeah, that's what they're asking.
From where? From where else? You mean
No,
outside
just
of
the
recovery?
difference between the 2 devices.
Oh, okay. It's kind of semantics, it's wording. Airvo is the device that drives the flow, and Optiflow is the cannula that you attach to it.
The ones that go into the nostrils.
Yes.
And then there was a question about patients who are COVID positive. If they're in a negative pressure room, can we use high flow? Now, we know that this is an aerosol generating procedure, and my comment would be that as long as the person who's attending the patient is in full PPE, and I'd also like to see an added safeguard of having something covering the patient's mouth and nose to stop that generation of aerosolation out. So even a simple surgical mask actually helps to trap that and stop it spreading very fast. So do you have any comments about that, Anna?
No, yeah, you're right, Ken. That's interesting. Studies done have found that nasal high flow is very effective in treating COVID positive patients for hypoxia, and it certainly is successful in reducing intubation. And some studies suggest, as Ken just mentioned, a surgical mask over the top of the cannula is going to help reduce the spread. And I think absolutely the use of nasal high flow is defined as an aerosol generating procedure. So you must absolutely have full PPE, whether you're in a negative room or not, whether when you use nasal high flow, that will be the default if you have a COVID positive patient, 100%.
Yep. Now someone's saying, is this available for patients in their homes? I'm not aware of that. Have you got patients?
There's a home device. It's the same device, but it's actually modified for the home. So you can absolutely, yes, you can.
Okay, good. And what about nurse-initiated use of the nasal high flow?
In some hospitals, it is no problem, and this is routine. When we see airbows distributed throughout the wards, it is nurse-initiated, and also actually in some recoveries. Of course, that's going to be completely driven by your guidelines, and that's what's possibly going to define whether you have nurse initiation or not. It appears that the research suggests that that is good practice. We're not there yet, I don't think. I think perhaps more research needs to be done, but there are a lot of hospitals that practice that already, and that'll come down to your individual guidelines.
That's correct. And also the anaesthetists and their confidence with the staff who are going to be applying them for appropriate reasons. So it doesn't always need to have an anaesthetist to prescribe it or dictate that it needs to be done.
Well, exactly. When you think about it, it's air often. So that's kind of what you've got to think about. And it's flow.
Now, someone's saying using a face shield would probably stop more spread, but we now know that face shields by themselves do not prevent the aerosols from escaping from underneath it or being inhaled. So they'd still need to have a face mask on as well.
Yeah.
Now, someone's asking about if the patient is currently using CPAP, can it be replaced by this device at home? And the answer is no, because CPAP is a closed system circuit providing positive pressure both on inspiration and expiration. And this device is not a closed pressure system.
Yeah, absolutely. And look, you will not get the same pressures you achieve with CPAP in the home. And you're right, CPAP is a sealed pressure-driven device. This is not. It's interesting, they have done some studies on that, looking at very mild forms of OSA and treating it with high flows. It's like leaky high flow, but it will not provide the same pressures. So no, it won't achieve the same result.
Now, I just got someone here saying that the QR code is webinar 1, not 3, but I thought we'd have checked that. So maybe if the tech team can look into that. There's quite a few things coming in. Look, we're pretty well over time, people. There are quite a few other questions. Why is there evaporative fluids in the tube? Well, as the tube cools down to room temperature, then if the temperature of the device is not set high enough, you'll get rain out, condensation within the tube. So that's probably an indication that you actually need to increase the temperature for the given flow. What do you think, Anna?
Yeah, look, the circuit's pretty robust as it's got a coiled circuit heating circuit within it, and that does most of the work to keep the gas warm. But there are certain challenges that will really stretch the heating of the tubing. So once the tubing maxes out on its heating, there can be some beading in the system, perhaps in the cannula as well. I would absolutely look to see whether there's a fan on the patient. That causes big challenges. Aircon units can cause a big challenge, or if the flow is very, very low, the circuit can struggle to heat. But it's pretty robust in terms of the thermoregulation along it, generally.
Yep. And someone's asking, should we be connecting only to oxygen and not, to air and not oxygen? And the answer is no, because we titrate the oxygen to the patient's saturations, and you can't increase the FiO2 if you've just got room air or your medical air going in.
Yeah, exactly. I think the beauty is the fact that you've got the ability to do that. You've got air, but you have access to the oxygen. So you've got much more ability to support the patient. So absolutely, yep.
Yep. Now we have a range of other causes coming up relating to acute life-threatening emergencies. We've got anesthesia and recovery room, in the day surgery setting, anaesthesia and recovery room in PACU. We're also doing some face-to-face courses in Sydney and Brisbane because they're not subject to the lockdown restrictions. And those courses are in basic and advanced life support and pediatric advanced life support. And you'll no doubt be getting some EDMs and Facebook notifications of those now that you're part of the Medcast group. So maybe we might see you at some of those. And I'd like to thank Anna for her excellent presentation once again. This will be recorded, as have been the previous ones, so that you'll be able to go back and actually look at those. And I'd like to thank Fisher and Paykel for their support for these webinars to help make them possible. I hope that you've enjoyed them, you found them to be interactive and informative, and that you can actually use this information in your clinical practice. So thanks to the tech team, Greg and Abby, for their tireless work in the background, and we look forward to seeing you at future webinars. Thank you, Anna.
Thank you,
Talk
Ken.
to you in
Thank
about
you for the
5
opportunity.
minutes.
Okay, thank you.